thanks again for another day. Father God, as we come to another, as we are here to have another class, Lord, we just pray for your divine guidance. Even as Hello Jean right now, Lord God, is having some difficulties, we just ask that you will just touch the instrument in a special way, Lord God, that she may be able to come through. Be with us, guide us, open our intellect, Lord, open our understanding, Father, that we may understand what is being taught to us by Dr. Mac. Lord, we just thank you for everything, and we thank you for Dr. Mac and the Kojo. In Jesus' name, amen.
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 All right, ladies and gentlemen, we wish to thank you again for joining us for week 3 lecture. And tonight we hope to look at the DSM-5 as well as Group 1's presentation. And I hope to also discuss object relations and attachment. If we don't finish, which I don't anticipate we will, we are going to be continuing this coming Saturday at the same time at, I believe it's 6 o'clock Jamaican and 7 p.m. Guyana and Atlantic Standard Time. At this time, without any further ado, I would like to invite the Group 1 to comment their presentation on dissociative identity disorder. I do see where Hello Jean has joined us.
She's right there.
Okay, so please go ahead now, Group 1, before we lose any momentum.
Okay, Dr. Mac. Kojo?
Yes, I'll be sharing my screen, so I'm hoping that this will work properly.
Hello,
I'm sharing my screen and you.
Are we hearing you?
Tell me if you're seeing my screen.
Yes, we are seeing it. Oh, it's gone. Go again. Yes. It's gone. Hello, Jean?
Yes.
Okay, great.
You can hear me?
Yes.
Yes. Praise the Lord.
Hello, Jean, we have an hour, so you can go through.
Okay, tell me if you're seeing the screen now.
Yes.
The challenge is that when you are talking, it may switch. So I will try to see how we can keep it on there. Okay, Michelle, who's gonna start off?
Hello, Jean.
Hello, Jean, can you?
Hello, Jean. I was just saying that Dr. Max says we have an hour, so you can just go through.
Yeah, man, I hear you. I hear you.
Okay. All right, go ahead.
Start.
I'm going. Before you start, I need you to say something, Hello, Jean. Don't start, but talk about something. Hello, Jean?
About anything?
Yeah, anything. Talk about a testimony. How did you come on? I just want to go to the presentation and make sure that when you're talking, I'll have to keep I may have to keep you may have to keep clicking on my where my face should have been. You'll see the presentation. So if when you're talking it goes to your face, I want you to click on the presentation, okay? Click on my
Is that because you want? Is that because you want me to
see what's there? I want everybody to see what's there, so I don't want it to not be sharing my screen. Are you seeing my screen now?
Yes, I'm seeing
the presentation. Are we all seeing the presentation? The front page?
Yes.
The thing is that when you talk, the person who talks can take it away. So I just want to make sure that she'll be able to see it. Hello, Jean, is there still?
Yes, I'm here. You can hear me?
Oh, I couldn't see you, but continue. Okay, start in Hello, Jean. Let's see what happens.
Okay, good night, everyone.
Good night. Good evening.
This is a partial fulfillment of the Childhood and Adult Psychopathology course offered by Caribbean Graduate School of Theology. Disorder to be presented is dissociative identity disorder. We'll be presenting Hello Jean Hepburn, Michelle Ross Williams, and Latoya Cameron here. At the end of the presentation, students should be able to define dissociative disorder and types, and dissociative identity disorder, cause and the diagnostic criteria and etiology of psychiatric disturbances, and understand the cause of the disorder, identify the cause of the DID, discuss ethical, cultural applicability to the Jamaican or Caribbean context, understand the role of the family factors. The skill being used will be using a variant to explain the diagnostic criteria of DID, and the attitude is to demonstrate understanding of how to help DID patients. Okay, what is dissociative disorder? According to Roger, dissociative disorder is a coping mechanism that a person uses to disconnect from stressful or traumatic situation, or to separate traumatic from normal awareness. It can also be.
Hello, Jean?
Yes.
Hello?
Hi.
We're having, I'm having a share in my ears. Can we, Mr. Miami, can students mute their mics, please, while she's presenting? Please. Go ahead, Helen.
Dr. Mack, could everybody like mute their mics apart from who will be presenting?
Yes, please. Go ahead. For persons who are not presenting, may I ask you to mute your mics, please? Only the persons who are presenting must have their mics unmuted. Go ahead with the presentation.
Okay.
But much better.
Right. Where am I? Right. So basically what I just said is that the dissociative disorder is a coping mechanism, and people use it in order to disconnect from the stressful or traumatic experiences that they may have, and hence it separated traumatic memories from normal awareness. It can also be seen as a primitive defense mechanism. Now, dissociative disorders are psychological disorders that involve a sudden loss of memory or change in identity. It also exists on a continuum of severity. Now, at one end of that continuum, dissociative experiences like daydreaming, right? And at the other extreme, it is very complex and chronic. So this is, for example, dissociative identity disorder. That's one of the chronic ones. Now, there are 5 dissociative disorders. Dissociative amnesia disorder. This basically is where an individual loses their memory caused by extensive psychological stresses. There is the dissociative fugue, which means basically flight disorder. This is where the person not only have amnesia, but they also have unexpected travels away from home and assume. And there is a depersonalization disorder, which is an ongoing or repeated sense of detachment, and pretty much the person feels like they're outside of themselves, observing their actions and their feelings and thoughts and self, basically like they're dreaming as well. The dissociative identity disorder now is a severe form of dissociation, and the 5th one is other specified dissociative disorder, which is a complex disorder that establishes itself during childhood from child abuse and lack of attachment from their primary caregiver. Now, what we'll be focusing on is dissociative identity disorder. And the definition for that is a severe form of dissociation, a mental process which produces lack of connection in a person's thoughts, memories, feelings, actions, or sense of identity. Now, when you have this particular disorder, there's a separate, clear personality also known as alters. now existing in only one person. So there are several alters and they exist in only one person. And that alter may control the behavior or attitudes leading to internal struggles and confusion of over issues of the personality, identity, right? It was first, the idea was first known as multiple personality disorder, and the pioneer for this disorder is Pierre Janet, which came about with it in the 19th century and was first, yeah, in the 19th century, sorry. Now, the Western civilization believed that demonic possession was a historical precursor of DID, and many patients were basically treated by exorcism, but it was not successful because that's not the problem, so that couldn't have been the cure. There is the diagnostic criteria. Now, in the diagnostic criteria, that is in the DSM 448.1, A, it says disruption of identity characterized by two or more distinct personalities, which may be described in some cultures as the experience of possession. Now, I did a VANET to help explain the diagnostic criteria. So if you look on the slide, you'll also see the case on the opposite side. Now, this is a case pretty much where Eve had two personalities, Eve black and Eve white, and they would just take over at their convenience. Now, if you observe the case, you'll realize that for the diagnostic criteria 1, it basically, for the first paragraph right there, that is where it actually affects Eve, where Eve was the original dominant personality, and she had no knowledge of the second personality, Eve. So there you can see where Eve has more than one personality, which is basically what the first criteria is saying. Now, criteria B is recurrent gaps in the recall of everyday events, important personal information and or traumatic events that is inconsistent with where is it? With ordinary forgetting, sorry. Right. Now, in the case, we didn't see any criteria B, but basically that is saying that, you know, the person tend to forget personal information like who they are, where they're from.
Hello, Jean, be there.
Oh, sorry, Eve there. But that's what really happened. So for Eve, right. So where she leaving Eve white with hangovers, bills, and repetition in local bars that she could not understand or explain. So pretty much after she went out, she basically took on a new personality and she didn't even know of the things that she was doing. And hence, when she comes back to being Eve white, that was Eve black. So when she come back to being Eve white, she had no recollection of all that she had done the night before. She just see bills and know that she have a bad reputation in the bars because of what Eve black did. Now there is diagnostic C, where the symptoms are they cause clinical significant distress or impairment in social, occupational, or other important areas of functioning. And again, in the case, we see where Eve black was carefree, mischievous, and uninhibited. So she would come out at the most inappropriate times, right? And that's exactly what criteria C is saying. It basically affects, for example, maybe Eve black may come out when she's at work in a meeting. That's just an example. And that is what criteria C is saying, that pretty much it comes out at the times that is not very appropriate, so it may affect her occupation, it may affect her social life, and, you know, impair her functionality. So criteria D, the disturbance is not a normal part of broadly accepted cultural or religious practice. Note, in children, the symptoms are not better explained by imaginary playmates or other fantasy. So they will consider the behavior, it is not there, but they will consider the behavior to be strange. Wow, I don't know where the presentation gone. They'll consider the behavior to be strange and pretty much not acceptable, because culturally they are not used to seeing stuff like that. So it would be considered weird behavior or unacceptable or, abnormal. And then in criteria E, the symptoms are not attributed to the psychological effects of substances. Or another medical condition, example, complex partial seizure. Now, criteria E was demonstrated at the top where it says, during treatment, a third personality, Jane, emerged. Now, during treatment, she was sober. No, the therapist, no, she wasn't under any sort of influence, no alcoholic influence or anything like that. So she was pretty normal, and all of a sudden she had a personality switch. So that is what criteria is basically saying, that without any substance abuse, without any blackouts or stuff, the switching or the other alter may take over the individual. Michelle? Hello? Michelle?
Yes, I heard you. I didn't
Yes.
have on the mute was off, was on. All right, so as we continue, we will be looking at the course of the dissociative identity disorder, DID. And studies have shown that there is an association. Kojo, if you could just, right, thanks. Studies have shown that there actually is an association between the DID diagnosis and a history of childhood trauma. There are a lot, and they are sustained continuous maltreatment over a period of years in their early childhood, and it starts between the ages of 4 to 8. Now, what's happening here is also that in order for them to survive such a stress, extreme stress, these persons would tend to separate their thoughts, their feelings, and their memories associated with the trauma that they would have experienced when they were younger from their usual level of conscious awareness. And in children, because sometimes it's present in children as well, they may generate problems with memory, concentration, probably at school, attachment issues also, and traumatic play. However, they usually do not present with identity changes. Rather, they present primarily with overlap and interference among mental states. And I believe this is probably where you'd have the imaginary friend situation coming into play. Now, the host, which is the main personality of the individual, also has personality states. As Hello Jean had mentioned before, alters. And alters is actually the short for alternate personalities. So persons normally just say alters. And these are present. And these alters carry certain traumas that the host is not able to manage, such as child molestation in the sense of sexual abuse, and whatever other kind of maltreatment they would have endured. Now, individuals can lose time with no memory of what happened for long spells of the day. And this frustration can lead to attempted suicide. And it has been reported that in a study that it goes between 6 clients will be unclear about what is real and what is dreamed or imagined, and it can result in a confusing existence, which also again can cause attempted suicide. However, treatments are available, but it is likely to be very long, somewhere between 2 to 10 years, or maybe for the whole life of the person. And the dissociative experiences is said to decrease with age sometimes. Okay. Now, in order to be able to determine if these persons have DID, there are methods of assessment that need to take place. Now, it says here that the DID is often difficult to detect without the use of specialized interview and or tests. And the reason for this would be because sometimes the hidden nature of the symptoms, or there may be coexistence of depression, anxiety, and substance abuse, which may also mask those symptoms, and also the feeling of disconnection that are oftentimes difficult to verbalize. Now, in my research, I came across 5 assessment tools. The first one is Dissociative Experience Scale, or DES. It was the first screening tool in 1986. And the second one, Dissociative Disorder Interview Schedule, DDIS, was the first diagnostic tool in 1989. So you can see how old these tools are. And the other one, Structured Clinical Interview for DSM-4, Dissociative Disorder Revised. Now, Dr. Mack, I could not find anything on the DSM-5 as yet, but it's pretty new since it came in last year, so we just ran with the 4, that's okay. And then the number 4 is the multidimensional inventory of dissociation, MID. And then the last one is the child dissociative checklist, because as we know, the children also present with this disorder. Now, just to quickly explain the dissociative experience scale, or the DES, Bernstein and Putnam, they were the first to come up with this screening tool for DID, as we said before, in 1986. And it is a 28-item self-report. It's a scale that measures the frequency of the dissociative experience, such as amnesia, depersonalization, or imaginative involvement. And it contains a visual analog for each of the items. And it provides a percentage of the time that the participant has experienced the symptoms. So there's a scale ranging from 0%, which means it has never happened to them, to 100%, which says this always happens to them. Now this scale takes about 5 to 10 minutes to complete, where the total is added and divided by 28, and the score is and they come up with a score, and then that would give them an idea where on the spectrum this particular person is. Now, what we're going to find in the other assessment tool, the DDIS, is that it's a little bit longer than the DES. It requires about 30 to 45 minutes to administer, and it takes 10 to 15 minutes to score. Now, this one has a little bit more to go through. It has 132 items, and this is a yes and no format, and it assesses the symptoms of the DID and the other dissociative disorders. It inquires about the positive symptoms of schizophrenia, which of course you know is a secondary feature of the DID. Well, now you know. The extrasensory experiences, substance abuse, and other items relevant to the dissociative disorder. And of course, depending on the number of yes or no's, the clinician again can determine where on the if this person can be diagnosed as having DID or not. The other one, the structural clinical interview, ... or the SCID-D-R, meaning revised. Now this is a little bit longer. It requires 30 minutes to sometimes 2 hours or more to administer, and it takes a little while to score, which is 30 minutes as well. Now this is a little longer. It has 158 items, and it assesses 5 symptoms of dissociation. There are 9 optional follow-up sections of about 10 questions, and these are designed to increase the understanding of the extent of the identity disturbance. So we're going a little bit deeper into the assessment. It is only necessary to choose 1 or 2 follow-up sections, and the choice is based on symptom areas endorsed in the earlier part of the interview. It also, the scores are also based on frequency and intensity of the symptoms, and it reflects the impact of dissociative symptoms on the individual's social functioning and work. The other one is the child dissociative checklist, and This was also developed by Putman and his colleagues in 1993, a little bit later than 1986, to assess dissociative symptoms based on rating by caregivers for children and adolescents. And it comprises just 20 items on a scale ranging from 0, not true, to 2, very true. So it's not a wide scale. Now these ratings are summed up, and the cutoff score equals to or greater to 12 is considered abnormal, particularly in older children.
Going behind.
What keep them in?
No, the etiology of the psychiatric disturbances of the DID, or the cause of the DID, it can be considered on the multipath dimensions. And even though psychologically post-traumatic stress, or PTS, is the most influential perspective, it may not be sufficient enough to explain why this disorder can happen in some persons. So there are other dimensions that we can look at. Quickly, we can look at the psychological dimension, and this dimension conceptualizes DID as resulting from extreme and repeated trauma that occur during their childhood, and it involves emotional, physical, or sexual abuse. There are other factors too that are necessary for the development of DID, and this includes the capacity to dissociate, the encapsulating or walling of the experience, and developing different memory systems. For the sake of time, I'll go through the social and sociocultural dimension, because it speaks to, this is a model, the socio-cognitive model, SCM, and it conceptualizes that this disorder, the person learns the phenomenon and its characteristics through mass media. So persons might see it on TV and figure that maybe this is something that they would like to experience or be. And so what would happen is that due to the vulnerability, they can demonstrate these behaviors when therapists provide the appropriate cues, because it says under the right circumstances they can enact these roles. Now, one therapist actually said that it was like an iatrogenesis, which actually means that the disorder was manufactured by the treatment or the expectation of the therapist. And if you get a chance to watch Sybil, you'll, well, not watch Sybil, but persons have said that the Sybil person, the actual person, her 16 personalities were actually put on by the therapist. So there is something to that as well. There's also the psychodynamic, which again has to do with the whole family dynamics and relationship, which we spoke of. But let me just look at the biological perspective. I don't think we have, most persons kind of think about that as well with the DID persons. Studies have done to compare the hippocampal and the amygdala volumes in patients with DID, and it shows that persons with DID, with persons who are healthy and with no psychopathology, and the results show that persons with DID had a smaller hippocampal and amygdala volume compared to the healthy subjects, and the patients with DID also had a diagnosis of post-traumatic stress disorder, or PTSD, using the clinician administered PTSD scale. And there was also consistency with the correlation between both of them as being a factor in its development. And then we just hand over now to Latoya to give us a differential diagnosis.
Latoya.
Hi everyone.
Good evening.
Hi.
We have 35.
So for the differential diagnosis,
just to give you a time, we have 35 minutes.
Okay. The idea is still viewed with some skepticism. Therefore, when we are diagnosing this, we ought to be very cautious, conservative, and thorough in making correct diagnosis. And as stated by Carr, differential diagnosis involves comparing the patient's symptoms with diagnostic criteria for other dissociative disorders such as the psychotic disorders, affective disorders, personality disorders, symptoms of substance use and general medical conditions, fictitious disorders, and malingering. So I'll go into them a little bit more. So we have the post-traumatic stress disorder. Sometimes individuals with PTSD manifest symptoms that also occur in DID, such as amnesia, dissociative flashbacks, negative alterations. We have the bipolar 2 disorder. DID patients are sometimes misdiagnosed with bipolar 2 disorder. They relatively have rapid shifts in mood, which is a contrast, and this is much slower in the bipolar disorder patients. There is the major depressive disorder, where patients are chronically depressed as they struggle to maintain any kind of stability. They have inner fragmentation and there is chaos in their life. So it is hard for them to be in any one personality at a given time, for them to be in one personality for a long time. So there's instability and there's a struggle. Rigorous assessment indicates that DID's depression in some cases do not meet the full criteria for major depressive disorder. I'm coming. Okay, we have the schizoaffective disorder or psychosis. This is where DIDs present with a schizomedian first-rank symptom for schizophrenia. Therapists may associate the combination of auditory hallucinations, attentional difficulties, confusion, and chaotic behaviors with psychosis and make diagnosis based on this subset of symptoms. The distinction, however, between the two disorders is the predominance of dissociative symptoms and amnesia for the episodes, and diagnostic evaluation after cessation of the crisis can help to confirm this diagnosis. And then we have the bipolar personality disorder. Characteristics are similar to both disorders. There are low self-esteem, impulsivity, substance abuse, chronic boredom, identity confusion, temper tantrums, manipulative, and suicide attempts. Therapists will find that the nature of countertransference helped to distinguish between the DID and the person with the borderline personality disorder. Patients with BPD tend to push all their buttons, while a DID patient will tend to mobilize their protective instincts. And research has shown that 70% of patients with DID are misdiagnosed as borderline by observing the patient's abrupt personality changes within the diagnosis.
Okay. We're going to speak about the ethical and cultural application. Now, in regards to the ethics, it is extremely important that we include ethics when we're counseling DIDs, because we do not want to compromise our practice. Now, the ACA Code of Ethics, this 2014, states that professional values are an important way of living out an ethical commitment. It also states that principles are the foundation of ethical behavior and decision making. Now, there are several ethical conditions in which we considered when we're dealing with the DID patient. Now, first thing was the informed consent. The informed consent was considered because these are very technical patients we're dealing with. And being in therapy, right? And the information that is going to be passed on and what is expected of the individual needs to be explained. Now, given the nature of DID patients, it is important to warrant the approval of the informed consent and have them sign it. Because remember, these are persons who have different personalities, have alters. So you might be in a session counseling them and an alter emerge, another alter emerge, and basically decide that they do not want to be a part of that session. Now you can use the informed consent to show that they have actually accepted that they wanted to be a part of it. So you basically inform that alter that they are supposed to be a part of the session. So hence the importance of the informed consent. Now we have to avoid harm and personal values, and that is A4A. Now the therapist should respect the diversity of the clients in which they are dealing with over going on in regards to DID patients. And well, disorder is not real. Now, you do not want a therapist who believes like that to impose their values on the DID patient to them and ensure no harm come to this individual patient. The informed consent in assessment is also necessary because when you're going to assess, when the therapists are going to assess the client,
Okay. Informed consent in assessment. Prior to the assessment, the therapist should explain clearly to the client the nature and purpose of assessments and the specific use of the results. As in the case of DID patients, the use of the, or as in the case of the DID patients, the use of clinical hypnosis. So persons would have to understand that this is what's going to be used and how it is going to be used. Hello, Gina, are you back? All right, go again. Go to the next slide, please. Okay. Boundaries of competence. Again, the therapists need to practice within their boundaries of competence because you can imagine the problems that would happen if that doesn't take place. So training and supervised professional credential and experience is a must. Competence to use and interpret assessment instruments. Again, the therapists are expected to use only testings and assessment services for which they have been trained and are competent. In this case, maybe such as the DES or the DDIS. And proper diagnosis is very important. Care should be taken when diagnosing mental disorders, and all the necessary assessment techniques, such as the ones shown there, must be used to determine the correct treatment and care for the client. And this is crucial for DIDs as the disorder is very complex and can easily be misdiagnosed as schizophrenia. As well. I believe we are going to quickly go the ethical, the cultural aspect of it. We don't have a lot of time, Latoya, so you can just move into that now.
Take your time,
for the Jamaican context.
Okay, all right, then, Dr. Mack. Yes, you can move into the Jamaican context. Dr. Mack says we are to take our time. Go ahead.
Okay, within the Jamaican context, it is sometimes confused with schizophrenia or bipolar because of its abnormal behavior. Generally, persons are not familiar with the DID and therefore may even believe that a person with DID can be seen as demon-possessed and need deliverance. And deliverance is seen as the answer. So, explain DID DID may be seen as demon possessed and are in need of deliverance. Although some individuals may be presenting with symptoms such as amnesia or mood swings and have suffered abuse by a primary caregiver, such as maybe a mother abusing her child, it is the notion of a demon attack and possession that may have caused persons not to seek help from a mental health professional, but rather a religious leader. In our context, we see going to a mental health professional as something bad. So even if we know something is wrong with us, we won't necessarily seek professional help, but we rather go to a religious leader instead. Currently in Jamaica, there are no reported cases of DID. However, we believe that there are some cases that have not yet been diagnosed because Jamaicans are not really educated concerning this disorder. In a study by Douglas and quoted by Lisa Hanna, Minister of Youth and Culture, it is estimated that there are 100,000 children who are sexually abused and may be suffering from a mental disorder. 9 out of 10 of these children with a mental disorder may go undiagnosed or untreated. The government child psychiatrist, Dr. Shetty, advised that factors shaping the development and future of our children after sexual abuse is their level of resistance. He further stated that if the perpetrator was a stranger or family member, it makes no difference. Abusive relationship or have multiple personalities, though the latter seems more common on television. So from the studies, we realize that a lot of our children are being abused sexually, physically, and it becomes a learned behavior. So the relationship they enter in they may also enter abusive relationships, and in the long run can have multiple personality disorders, though not yet diagnosed in Jamaica. When a non-corroborated trauma history is provided by a patient satisfying the diagnostic criteria for DID, it is noted as reported or alleged, but it is not crucial to the diagnosis. Even a corroborated trauma history with intervening amnesia does not justify a casual approach to assessing the diagnostic criteria. Although there currently is no data on DID in Jamaica, the alarming high incidences of sexual abuse is enough to suggest that our children are at risk of developing DID. Now, we all have families, whether immediate families or extended families, and we have a role to play when our relatives have DID. So many families struggle to truly understand and accept the diagnosis of DID. It's an overwhelming idea to know that your family is now a distant memory and can be too much for persons to handle. The constant and drastic changes in loved one can be overwhelming for family members and friends. They might feel helpless, fearful, or even enraged.
So children have to adapt to this new and sometimes frightening reality, and this can have negative effects on their relationship with their parents.
Thank you, Michelle.
Welcome.
Now for the effects on the family, there are emotional and physical effects, and there are negative effects on the children. For the emotional and physical effects, varying alters can also have drastically different feelings toward their friends and family members. So while one alter might be a pleasant one, the other alter might be very harsh, very negative. Where one alter loves their partner and children, a different alter may violently dislike them or don't even recognize them and may sometimes see them as strangers. And this can be emotionally traumatizing for a child or a husband or a friend. The negative effects on the children. Some children act out in school and home as a way to cope with the immensity of what they are going through at home. So whatever is happening at home, the child might go at school or on the playground and act out what is happening. Feelings of rage and hopelessness are also prevalent in these children. So a child might see his or her mother act in a particular way and feels hopeless because they cannot help the situation. And here's a clip of a mother with 20 personalities.
Everyone, I'm gonna start the clip, but you're gonna have to click on your YouTube icon to the left of your screen to see it.
Have you put it up yet?
I'm putting it up now.
Okay, fine.
But can you click on your the right screen and see if you can see it for me? Click on the YouTube icon. It's on your left. Just move your mouse over to the left.
The chat screen?
No, the screen that the list of options that comes up, it has a little red button.
With the pencil?
No, a red button.
The one at the bottom.
Well, probably at the bottom for you. If you mouse over it, you see it says YouTube.
Oh, so it's the red with the arrow.
Yes.
Okay.
So yeah, click on that and tell me if you see a screen there.
Yes, we see a blank screen.
You see a blank screen?
Yeah.
Yes.
No.
Look at the left. Look at the left, Theology, for the YouTube icon.
Just move your mouse to the left of your screen and you see, oh, she's on a tablet. I'm not sure you're gonna be able to view it, Theology. You may have to move the mouse. You move your, see if you can see something that say apps there.
I see.
Okay, can everybody see it?
Yes.
Yes.
I'm gonna start.
Do we see accept?
I see welcome to YouTube in Hangouts. That's where I should be?
Yeah, and accept if there's any acceptance there. This is one time you can accept.
Okay.
Are you seeing it? I haven't started playing yet.
No, what
It
yes?
says opening.
Okay, let me start.
Time the personalities come out, I'm
Yes, it has started.
I may never come back again.
With help from Kim Noble's therapist, Kim's alternate personalities
Time the personalities come out, I'm afraid that I may never.
With help from Kim Noble's therapist, Kim's alternate personalities come out one by one. First, knowing it's time for Bonnie to leave, she bursts into tears because she doesn't know when she will see her daughter again.
Hey, Pop.
A little while later, Ken emerges. He's 21 years old, homosexual, and doesn't acknowledge he is one of many personalities.
Hi, Ken, I'm Kristen.
Can stop it now, Culture, please.
Now you click back on your YouTube, the YouTube icon to come out.
Okay.
Okay. Let me go back to the.
Continuing with the role of the family and the negative effects on marriage.
Wait, on the PowerPoint.
No, she does to read.
Okay. All right. Go ahead.
So building a trust, filled and loving relationship can be difficult when bearing altars frequently appear, and trust has to be rebuilt with a partner and each of the different altars. For instance, when a childlike altar is present, the partner is encouraged to play with their loved one to try to build trust that way. Physical intimacy is especially difficult with a couple who is dealing with DID, especially since this disorder is created through physical and sexual abuse. Kodja, I'm hearing an echoing.
Someone need to mute their mic. Maybe it's me.
So continuing with the negative effects on marriage, as stated by Casserel, certain positions, sounds, or touches can cause dissociation in their partner, as due to the DID's historical abuse, physical intimacy may trigger switching of altars. So sounds, position, or touches can trigger the switching of altars. During intimacy, if a person continually switches between altars, they can end up feeling scared, withdrawn from reality, and even view their partner as the perpetrator. So couples now have to work together with their therapists to attempt to learn new ways to have physical intimacy. And now we have another clip on a husband with
24 personalities, which actually came down to 4 with age.
I'm trying to get the video up. You can click on your YouTube icons to view. Okay.
Can you move it along, Kojo? You're going back to the beginning. Yeah, that's fine.
I don't know what's that.
Yeah, it's okay. It keeps going back to the beginning, but I think it would have. Oh, all right, good, great.
Okay. Some persons weren't able to hear, but I'm not sure what happened.
Okay. All right, so continuing. I don't know where Latoya went, but let's just continue.
Yeah, man. Possible support
Hello, Jean?
association. If the family, the DID, basically, they feel a sense of relief that they see that other persons have the actual disorder. This new knowledge gives them a better understanding of PID and how it impacts their loved ones. Also, the family and friends learn how to cope much better. Can others mute their mic, please? Okay. Support provided for the PID from the family. The relative or friend can help by identifying orchestrate a switch, and they can remind the patient of coping so that might be is violent. Then the good thing is they will know how to it helps. You can help them to relieve of stress and tension. The family and friends' ability to assist the patients using these elements will relieve some of the stress and the tension in which they go through, especially if they have to live with these individuals. So messages, you can also encourage, family can also encourage the individual to leave messages to the different altars so that basically they will know what each altar has been doing, in the absence. And pretty much if they have a meeting, they'll know that they have already attended that meeting already or call who they need to call. And so therefore they will be more functional. Also, it is possible for so therefore,
Say it again.
Say what again? Say what again, Michelle?
It is possible. It is possible. Also, it is possible for
It is
alters to
possible
leave.
for alters to leave each other messages if they are not conscious. That's what I was just explaining. So, for example, you can suggest that the alter who accomplishes a task leave a note for the other, for the host.
So when he or she returns, they know exactly what has taken place.
To say that, hey, I have already gone to that meeting. So they basically can be more functional. Yeah, so in conclusion, dissociative identity disorder can be considered one of the most complex, more misunderstood and deliberating of mental disorders.
Diagnosing DID can be problematic as it associated symptoms
As it
are shared.
associated with so many different symptoms and are shared with other mental disorders such as psychogenic fugue and amnesia, psychosis, and bipolar disorder. The DID can have a devastating effect on individuals, but a supportive family can assist by being aware of the characteristic features of the disorder. Empathetic learning and simple patience and understanding can help a family go through with their individual much smoother. Several ethical considerations must be addressed unique and complex nature of the particular disorder. In the Jamaican context, DID is not widely understood or believed to be present here. However, education is the key to understanding, preventing, and managing well. Basically, psychotherapy, cognitive therapy, and clinical hypnosis.
Hello, Jane, I just had to run over something for them because the PowerPoint is not there and you were going in and out. So they didn't hear a few of the points that you were making.
Go ahead.
So one of the things that Hello Jane was also saying is that in the Jamaican context, it is not widely understood or believed to be present. However, education is key to the understanding, preventing, managing, and treating. And even as you would have seen with the psychiatrists who believe that it is just something that we see on TV. And though we weren't supposed to look at treatments, just to mention that treatment involves psychotherapy, cognitive therapy, and clinical hypnosis. And therein lies the end of it. And we have also included a resource page with some other clips of persons with DID in different stages and phases. Koja, is it possible to bring up back the PowerPoint? Or not? Any questions?
PowerPoint is up, Michelle.
I'm not seeing it though.
Well, it's up.
It's only you're seeing.
We thank you. This is group 1. Thank you for your attention.
Why am I not seeing the PowerPoint? I'm seeing Kojo's face. Am I the only person seeing that?
The PowerPoint is up.
It's up.
I'm not seeing it.
Okay.
All right. Any questions?
I'm not seeing the PowerPoint either, but I was particularly interested in knowing what you guys make of the change in name from the multiple personality disorder to the DID, dissociative identity disorder. What do you make of that change? Anything on that?
Yes, there is something. Basically, they changed it because they were saying that they're not personalities. They consider them to be states. So it is multiple states and not really multiple personality. And so pretty much they're states with personalities. So pretty much what they've done now is just change it from multiple personality disorder because it wasn't just about the personality.
Right.
So it states, so pretty much that's why they changed it from multiple personality to DID.
Okay.
If you can recall, they also had called it split personality at one point.
Right. Thank
But
you.
The focus now is really on the identities and not the personality that the identity, the various identities display.
Okay, ma'am. Thank you.
You're welcome.
I have a question, Group 1. Thank you for your presentation. I wanted to know, not sure if I heard this, is DID more common in males or females?
Actually, what they said about that is that it's basically equal. There is no proof that it is more in male or in female. It is pretty much any other.
You got the explanation, Vanessa? Or is it just me
Pardon?
not? You
No, I
heard?
thought Helene got cut off. Sorry, I
Oh,
didn't hear the end.
oh,
Oh,
okay.
okay. You heard? You can hear me now?
We're not hearing you very
Yeah, I'm
clearly.
hearing you now.
We're hearing you now. You have to say it again.
Oh, you can
You're
hear me now?
saying it's prevalent between both males and females, is that it?
Lord of mercy.
Equal.
Michelle.
It's equal.
It's equal.
Yeah.
Okay.
It's equal. Yeah.
All
There's
right, I
no
have one
predominant.
other. There's no predominant. Okay.
Yeah.
One
No.
other question from me. In relation to the dissociative experience scale that you mentioned was introduced in 1986. I was just wondering, prior to that time, you also mentioned that I guess in the ancient times, DID was treated through exorcism. Am I correct?
Well,
Right.
I was
So
actually speaking from the Jamaican context that they sometimes believe that exorcism would be. Oh, you mean before?
yeah, I think
Oh, yes,
Jean
yes,
mentioned that
yes,
somewhere in the introduction, right?
yes,
So I
yes.
was wondering, prior to 1986, was exorcism the only method of treating DID? Because you mentioned that at that time, this is when the first scale was introduced.
Between exorcism and the scale, I didn't find anything at all between that
You
time.
didn't find anything.
Yeah.
No.
Okay.
Michelle,
All right. Thank you.
Guys, may I put in my question?
Yes, Miss Latoya.
All right. So, I'm Latoya.
Thanks, Vanessa.
Sorry. I was very interested in the point that you made that there were no reported cases of DID in Jamaica. Yes, it is that we may come across persons, not very frequently, we may come across persons who demonstrate the this symptoms or signs of this disorder. But then you rightfully said that it's oftentimes misdiagnosed with schizophrenia. Could you elaborate just a little bit on the reasons outside of that? Do you find anything else? Because I'm wondering in my head, outside of this misdiagnosis of schizophrenia and DID, is there anything else that you might think in regards to our culture that cause the lack of what should I say, diagnosing of this particular disorder?
as mentioned,
There was a section that said that individuals may be presented with symptoms because they believe it's a demonic attack. When Latoya was presenting.
Yes.
So sometimes they may believe that they're under demonic attack or they're under some kind of possession. So because of the prevalence of that in our culture and the lack of understanding of DID in our culture, sometimes they misunderstand all of those coming out as attack or possession, and so hence them not seeking mental professional help. But the point that was to have been made out of it as well is that the high levels of sexual, not really sexual abuse, the high levels of abuse. It's actually 10,000 children that Minister Hannah had said, and the top five of those are sexual abuse children. And so it stands to reason that if it is that we have 100,000 children that are abused, and the top five is sexual, and we know that some of the issues that can cause the DID is out of trauma as children. We believe that there must be persons around that do have DID, but again, it comes back to the fact that they might not be under, they might not know what it is and have some kind of a different understanding.
Can I beg to say though that in terms of how our culture view disorders, mental disorders, would it be anyway plausible to argue that it's not that our children or persons really deal with DID, deal with this trauma by the trauma manifesting rather in DID, but are there situations in which they just find other ways of dealing with these situations and then not manifesting itself? Sorry.
I don't understand that question. Say it again.
It's not a question, it's a statement.
Oh, okay.
I am saying, is it plausible, and based on your research, you can correct me if I'm wrong. Is it plausible to say that find there are evidence of so many cases of child abuse, but can we argue that based on our culture and our way of dealing with trauma, it does not manifest itself in DID? Rather, we find other ways of dealing with it instead of having that prevalence of that disorder coming about as a result of this trauma. Am I making any sense?
Yeah,
that
man,
could be so, but and those other ways would be what you think?
Well, we are a very, how should I say? We are used to so many challenges, so many issues. As that observed the video from last class, diversity and mental illnesses, in terms of as a people, as Black people, as Caribbean people who are associated with a history of oppression, a history of abuse, is as if we internalize them
and we are able to better manage it without having to see
it. Manage, that's the key word, Michelle. We manage it without it becoming a problem or mental case, because even in looking at this disorder, is a lot of and not to sound racist in any way, it's a lot of Caucasians who are associated with this disorder. I mean, Dr. Mack can correct me if I'm wrong here, or you can in your research. But I think it may be connected as well to our history, who we are as a people in dealing with stress and dealing with these situations, as Dr. Kwame Mackenzie has said in his video.
I agree with what you're saying.
As a follow-up to Lataya's point as well, I was wondering, I don't know if you found in your research group one any evidence of the assessment tools for DID being used in the region, because that might also be one reason why we're not aware of the number of incidences of DID in the region. I don't know.
Didn't see anything. Went on EBSCO Caribbean checks, didn't see anything like that.
Of the assessment tools being used in the region.
Yeah.
So that might be a reason why we don't know whether it's prevalent, because we're not assessing it in the way that we should.
Yes.
To know whether or not it exists in the region.
That's a valid point, Vanessa.
Yes. Yeah. So it not only is it education that we need to top up on also, but how we assess the
for the actual disorder
being done. Yes.
For the actual disorder, right?
Yes.
Because I share the view expressed by the group. I think if a parent saw a child displaying even two personalities, based on the culture in the Caribbean, the first thing they would want to do is rush them to some church leader, some spiritual leader for prayer. You're not going to carry them to the psychologist.
Absolutely not.
Right.
They need a path.
Maybe this is why we don't know, about how many incidences there are in the Caribbean.
That's right. Yeah.
If I may chime in here, I think that one has to make a distinction between disassociation as a defense and disassociation as fragmented ego states. Certainly in my experience, what there are two levels of that. So the identity disorder means that that the disassociation, people do have disassociation in the Caribbean. And so while we may not have necessarily the fragmented ego states where you have several ego states manifesting itself, you do have this association. Especially children children do have this association in Jamaica. I've seen it in play. And I'm certain that there are people who are disassociated. It's just that we have not been able to. It takes a certain amount of understanding and skill to deal with it. But there are people who are disassociated, I believe. Rape victims can manifest that. Traumatized children, people who have undergone tremendous trauma can show some level of disassociation. All right?
Yes, Dr. Mac, thanks.
I have a question. I don't know if it was said and I did not hear, as my thing structured sometimes. Are there any developmental issues that may be misdiagnosed as the individual having DID? I don't know if it was said and I did not hear it. For example, a teenager, just being a teenager, as we would have seen in the news with the Obama's daughters, where they just being teenagers are being accused of being somewhat being not fitting in kind of stuff. But as it relates to DID now, developmental issues, are there any developmental issues that could be misdiagnosed as the person having DID?
Well, developmental issues. Did not come across that anywhere. I don't know if Helogene came across it in her checks. But developmental issues in the sense of give me a little bit more,
okay. For example, a teenager would normally be rebellious somewhat. But that child could be diagnosed as having conduct disorder.
Okay. Okay. I see what you mean. They're actually in it. We spoke about the child having traumatic play.
Yeah.
Specifically for the child that they can have some kind of traumatic play. So it would mean, and I think Latoya had spoken to it, that they might be on the playground and exhibit some kind of, I don't know if that's what you mean in your question, and they might exhibit some amount of for want of a better word, antisocial type behavior. Maybe because they're acting out the trauma. That's about as developmental as I can come up with right now. I don't know if
also they are saying they're actually acting and not, it's not being real in terms of they really are.
I wouldn't say they're acting out. I wouldn't say they're acting and it's not real. It's real. The trauma is real to them. And in other words, to be able to deal with it as children, because they wouldn't even know they know what is happening to them, but they don't know how to deal with it. And so I'm trying to find the section. Is there anybody who has this presentation who is in this section?
I didn't hear.
Oh yes, it says dissociation in children may generate problems with memory and concentration, attachment issues, and traumatic play. So attachment issues would come up, and as we do attachment with Dr. Mac, but that would be a developmental issue as well, because you have the different phases of attachment that they would that would be affected, and probably it would not, maybe not be the secure, I don't know, it could be the avoidance, not so sure, but for sure they would have attachment issues. I don't know if that helps or if Dr. Mac can help. Dr. Mac, you're on mute.
I'm saying maybe I need to chime in and do some rescuing from the choppy waters.
Thank you very much.
There are issues of disassociation in a child, especially disassociation in a child is seen in children particularly. They manifest some of the disorders, but it's, in other words, there is what I call cognitive blurring. They're not able to express or express the traumatic episodes or the traumatic event through expression. So it tends to come out behaviorally. So it may come out in terms of repetitive play, which is trauma, which is more the play itself repeats itself, and so you probably find a play in a play theme, which is really not a therapy class, but in a play session where the child tends to repeat the trauma over and over. So let me give an example of a child I treated a couple years ago, which was in a bath and turned on the hot water on his sister's leg, very, very piping hot water, and the child sustained damage, and she had a limp, and the child he blamed himself because she was very ill. She had severe burns and had to be hospitalized. And I remember playing with the child. He was started to act out. He was about 5, and he started to was brought because he was really acting out, and worked with him, and noticed that he took several plays where you find where the certain themes in play is that you use certain toys represent certain things, and I noticed that he started to have keep recurring about the same ambulance going to the hospital. And every week the play was more sparse, but then it started getting more where they had more vocalization, where you're saying that. So I asked him, tell me why this person keeps going to the hospital. Well, he has to go to the hospital because he hurt somebody. So I said, okay, who? Let's see if we can understand what's happening. So he recreated the scene where he had an ambulance, a child who was hurt, and there was she had was surrounded by a bed. There was she was on a saline drip, and she was in an ambulance. And he asked, I want you to come with me to make me feel safe. So he went to the hospital, and he was able to, through that scene, it took about 3 times, he was able to recreate what happened. So I sort of got in his head cognitive and asked him, what happened? So he said he began to play out and said that he hurt her. What he did, he was bad because he hurt her leg. So you see that, so you could see the trauma or the repetitious trauma coming out. So in a sense, the traumatic episode became behavioral. So in children, trauma is more disassociated is more repeated. It comes out as a behavioral manifestation, but it's repetitious. It becomes compulsive because it has to be resolved. Once you resolve it, it's gone. That's the difference with children. Unless it is the trauma is so severe, the child tends to do splitting. So they go through disorganized play, or they may have a disorganized attachment. So as we get to talking about attachment, it's important to understand, especially in disassociation, that there is disorganization. There's a disorganization of the ego states which are fragmented, but the states are they're repressed, and so they may manifest themselves in different ways. So if you notice, you have, that's why it's called dissociative disorders. Each disorder are fragments of amnesia, fugue state, and you have other and identity, but nevertheless, under one umbrella, they are dissociations. And what it is that there are symptoms, there are severe symptoms. So it can be anything that is traumatic episodes. So it can be sexual abuse, physical abuse, witnessing trauma, or trauma being done to them. So when we look at in terms of developmental, a person who develops developmental disorders or identity disorders means that what has happened is that they have gone through what is more like it's a derealization of the event. So they have again it's more a event where they have in their minds they have separated reality from the event from reality, and so it's in suspense, in repression. So of course therapy is the one to bring it out, but like I said before, in terms of the disassociation, you have different aspects of disassociation. So in the identity disorder, you have the fragmented ego states, but you have amnesia, you can have fugue, you can have derealization, but they're all they can be separate entities in terms. So no one person can have the same symptom, but nevertheless, that's why it's called disassociation. So developmentally, most of the disassociation starts in childhood when there is a very, very traumatic, difficult family dynamics. Parents can be very distant, or there's abuse. Like I'm treating a lady. I wanted to mention the case who they said she had DID. Up to now, I haven't seen it yet. What I sense she has is disassociation. She has had a history of systematic abuse, but what I'm seeing are periods of disassociative amnesia, where when she tends to, and so the memories are fragmented. And so what I'm doing is working with her to tap into that, to look at the disassociation. I think what has happened is that people have talked about or told her that she has DID, but I think more so it's a disassociation, because she talks about sometimes periods where she feels that she's floating. She sees in her mind, she can see an attic, and there's a hole. So if you look at it psychodynamically, you are seeing the unconscious play out. Her unconscious is playing out in terms of reality. So it is more helping her come to grips with it and deal with it. All right, let me hop off and you can and continue with the presentation. Are you done? Group 1?
Dr. Mark?
Yes?
Dr. Mark, based on what you just said, and a point that came out in Group 1's presentation, is that clinicians are the ones often responsible for assigning the ID to clients, I think I heard.
Yes.
Would you care to comment on that?
That is true. Well, in my experience, I have not, I think one has to be very, very careful in how one assigns this disorder. I think it's very, very rare. It happens in probably 1 to 2% of the population. What I find in my experience is that people do have disassociations, but not necessarily identity disorder. I think the matter of Sybil and the other classics or Faces of Eve are one of the classic ones. But but what I see is that to be able to truly diagnose DID, I think that one has to probably, as they say, go through some periods of using certain scales, not just the scales that they talked about, but there are other scales that one can use, like MMPI, for example. In an MMPI scale, you would probably see this association happening on scale number 1, which is the hysteria scale, hypochondriasis scale, and scale depression. There's a depression scale, which is 2, so you'll probably have some scales like 7 because so it's probably very, very, as I said, it's very, very rare for you to have DID. It's not to say that people don't have identity disorders, but like I said before, I believe it's just, as I said, it's more, they are fragments of ego states. So it's like trauma has been truncated in different ways. And so if people find ways of means of coping. In a true DID disorder, the personalities are not aware of each other. There is no memory of them. And there are one or two dominant ones. There's one, either the child state, either is an adult state. There is one that is normally hostile, and so a personality that can come out is one that will probably do violence. So people can have up to 30, 40 personalities, but so the more fragmented you get, the more the person's attempting to distance themselves from the painful realities. So one of the aim is for integration. And so you will start with you start with the state, the most dominant person or the dominant alter ego, and able to tap into them to see, because they, as I said before, this dominant person will tend to suppress the other alter egos. More than likely, in my experience, is that the alter egos, the child state is much more weakened, and so that's where the trauma is, because the trauma started from childhood, and it's almost like the child state developed layers and layers and layers of other personalities for protection. So once you get below the layers and get to the crux of like the child state where the trauma is, the aim is to integrate. But you have to do it in a way that is skilled, because if you can do more harm than good once you started to deal with the level of disassociation. For example, in my patient that I saw, for example, she just, her eyes just went glassy, and she was as if she was in another world, and there was derealization, and she was talking, she said she didn't, and she was asking, she looked frightened, she looked like she was in a state, and she was wondering where she was. And then she said, I don't know what happened. So I told her what happened. She was very, almost like hypervigilant. She was scared. She was wondering. It's almost like she lost tracks of time. She talked about tracks of time and memory. But I think that's disassociation. Like I said, I did not see, up to now, I don't see where she has an identity disorder. It's more disassociation because of abuse. So when people go through trauma is it's when trauma is an event that happens. They talked about two brain functions that does that: the hippocampus that deals with memories, and then the amygdala. So the amygdala, part of the left temporal, is the one that deals with, associated with visual memory. So a particular structure called the mammillary bodies that is implicated in having an emotional association. So people, even rape victims, the smell can trigger that kind of association, because the brain structure does play a great role in this association. Is it? Am I making sense?
Yes, Dr. Ma.
Yes, Dr. Ma.
Am I making sense?
Yes, ma'am.
Yes, Dr. Ma.
Yes, Dr. Mark.
Yeah, so basically, as I said before, it's a very rare disorder, but it does exist. But what I do find in my experience is more disassociation, not necessarily identity disorder. But it does exist. I believe it does, but I have not seen it yet. I've only seen once or twice, but more so now is disassociation. All right, ladies, anything else? Anything else? By the way, you did not talk about course. I noticed that.
The course is etiology.
Okay, well, I didn't see that at all, because I think I had a heading of etiology, so I was wondering where the course was. I was a bit confused. Okay.
No, the course is etiology. In your outline, Dr. Mac.
Mm-hmm.
It said, hold on, because I normally tend to follow these things directly. Hold on, let me see, sir.
Let me see, because I have course and I have course of disorder. I have etiology as two separate headings.
The course was there.
Okay, what did you? I must have missed that. What did you say about the course?
The course of the disorder. That
Uh-huh.
there's an association between DID and the history of the trauma. It starts at age 4 to
Okay.
8.
Yes.
That's on page 9. It starts on page 9.
Yes.
And you're saying, Dr. Mack? And that
No. Well, I'm familiar with the literature, so don't worry about that.
right, it's there.
Yes. Um, you know what you need to do, ladies and gentlemen, for this to be more real. There is a video on YouTube called Child of Rage. Child of Rage. There are 2 parts to it. I want you to go and when you have and watch it, because it will give you an idea about a child who has been severely traumatized, and it will give you an idea about this association in children. Child of it's on YouTube, so it's in the public domain.
Dr. Matt,
yes.
Just to be clear, all the sections that you have cited that we were supposed to do were done. So I think when you probably get a little chance to go back through, you
I will go back through it.
They're all clear.
And look at it. But are there any other questions for the other members of the class?
No more from me, Dr. Mack.
Any other questions, anybody?
No, Dr. Mack. I'm just particularly enlightened.
Okay, all right. Well,
thank you, everybody. And
thank you. I think that they have done a wonderful job given the constraints, and we want to thank them for the creativity in the presentation. So thank you very much.
Thank
all
you.
right.
Dr. Mack?
Yes.
Could you shed a little bit more light on what is it that you're expecting as it relates to the developmental issues that may be developmental issues at the appropriate age and the appropriate age range? What exactly are you expecting that?
Eileen, are you doing a case? Because if you're doing a case, that's the only time it would apply.
Oh. Okay.
So if you're not doing a case, Dr. Max says you would need to focus on that.
Okay.
Should be a case. Yes, it's a case. If it's a case, they tell us about the developmental issues. But like I said before, this really is. I don't see where you have DID in children. That's nonsense. I don't know of it, but I know you have where this association is progressive. It is progressive. It is not only progressive, but it's integrative and it's comprehensive. So it moves from childhood, where the child there is disorganization, to an organized. So in other words, there's disorganization in the child at a young age, to a more organized cluster of repression in adults. That's how it is, because DID is really repressed memories. Do you understand? Hello?
Yes.
Yes, Dr. Mack.
It's repressed memories.
Yes, Dr. Mack.
It's really disassociation. It's a dissociative amnesia. It's repressed memories, and that's why you have these fragmented egos, because there's an attempt to recreate the painful stimuli, and the personalities or the so-called ego states manifest and try to play out the trauma in terms of the ego states. Sometimes they are protective. They can be protective they can be aggressive, and they can be or they can be they can not only can they be aggressive, but they also are passive. If you notice, there are certain themes or elements of the personalities. And so you have 3 major events. The other fragment is that the more fragmented you are, the more repressed the disorder is. So you have to deal with those, and each fragment has to make a whole that you can, and you have one personality that you can deal with and tap into. All right?
Okay, Dr. Mack.
Any more questions on this topic? Are there any more questions on this topic?
None from me, Dr. Mack.
Is it clear, everybody?
Yes, Dr. Mack.
All right.
Dr. Mack.
All right. Okay. Well, thank you very much, ladies and gentlemen. I mean, group 1, I should say. for the presentation.
You're welcome, Dr. Man.
All right. Let's see if we can. I don't think we'll have maybe about a half an hour for more lecture. This is what I said, that we may not have time to complete. But what I'll do is that I'm going to launch into the. I don't want to touch the DSM tonight. The night is far spent, and but I want to continue on the introduction to childhood developmental psychopathology in leading up to the DSM. I think I want to touch DSM on Saturday when we're all fresh and I'm in my prime. I talked about in developing and understanding the topic. See what I've been talking about, that we cannot negate or we cannot not include attachment, and we cannot not minimize the role of object relations and attachment in disorder in the disorder. So I said last time I talked about the role of what I call pathways that deal with adaptation and maladaptive behaviors. So in the developmental spectrum, that came up a lot. Some people ask a question about developmentally, what it is, because the disorders of the DSM are really based upon a continuum. That you start the premise of development, and you start the premise of looking at behavior as a matter of a starting point, a reference point. So most behaviors starting with childhood. It is said that the disorders of the DSM start with what is known as neurodevelopmental disorders, and they continue. So
I'm sorry,
disorders that are
just one quick question. We are discussing what right now? I'm a little confused because
I'm continuing on developmental psychopathology.
Okay.
I'm leading up to the DSM, which I said I won't start tonight, but I'm just making a reference to that.
I'm just thinking,
yes.
Because when we left off a dimensional and categorical approach. So we're not going to pick up. We're picking up.
No, we left the dimensional and categorical approach of which I briefly talked about the DSM. Okay. But I'm leading that in terms of looking at developmental psychopathology.
Okay.
And to talk about adult psychopathology in leading with the DSM. Developmental psychopathology and adult psychopathology.
Okay.
In the syllabus, it talks about introduction to developmental psychopathology and adult psychopathology.
Okay.
We did talk about the dimensional and the categorical approaches to the DSM. However, that will remain in depth for Saturday.
Okay, then, Dr. Mann.
I'm trying to just conclude and provide a basis for that. So what I'm saying is that the DSM really is a developmental, looks at disorders from a developmental perspective. It looks at disorders, even though they are adult disorders, but there's really a continuum. It's a continuum. And it's based really on the adult life cycle. So the disorders of the DSM do have range of severity. Ranges of severity of symptoms. The disorders are also based upon what I called from a ecological perspective. In other words, people are seen within the ambit of the family and society. So most of the disorders do have a social representation. The family dynamics are important. Especially in children, you're going to have the ecological model is important. So let me look at, get my notes here. Let me look basically and finish this on terms of understanding the pathways of adaptation. So in children or in adults, people tend to have human behavior is governed by, as I talked about last time, about the protective factors, that there is a level of consistency in behavior. There's a level of predictability and stableness. Once you have those three ingredients, it sets the stage for a developmental stage that will progress. There's progression into maturity or maturation. If that does not happen, there is going to be what I call a disequilibrium of maladaptive behavior. A disequilibrium of maladaptive behavior. In other words, there is going to be a fixatedness in the life cycle. Freud talks about that. So let's look at then what it is in terms of the maladaptive behavior. That the DSM basically is looking at two concepts in terms of the developmental pathways. One, it is a concept of equifinality. You can take notes because it's the concept of equifinality. And what do I mean by that? In other words, diverse paths can be associated with the same income. In other words, a child, a person, for example, who has, let's say, for example, borderline personality disorder, which is a personality disorder. Equifinality says that you can have different ways of getting, having, coming to, having, or developing, I should say, borderline disorders, antisocial. It can be through association of gangs, destruction of animals, a dysfunctional family, difficult parenting. But however the different ways of that you have that the person is exposed to, it leads to one outcome, which is antisocial personality, depression, DID. So it leads to one outcome, different pathways to one outcome. So a child may go, or adult may go through different pathways, but once they have the same disorders, the symptoms are similar. The symptoms are similar. The symptoms are similar. The second approach in terms of the developmental pathway is understanding the DSM is known as the concept of multifinality. Multifinality. And multifinality is that there are hosts of impact of factors or influences that can lead to different outcomes. There are a host of different situations, but they lead to different outcomes. Let me give an example. So you have a family of five, a parent and three children. One becomes a priest, one becomes an artist, and one becomes a criminal. Each child has a different same family dynamic, got the same treatment, but they have different outcomes. That's multifinality. So, especially the neurodevelopmental disorders, or we look at the disruptive disorders in children, no one child in a family will behave the same way. Unmute your mics. Do you agree or you don't? Unmute your mics.
Agreed.
What are your thoughts?
Agreed.
Do all children behave the same way?
No, Dr. Matt.
So we look at the issue of multifinality.
Yes, Dr. Matt.
Why do you think that is?
Even though they would have grown up on the same.
Absolutely.
It might have to do with their temperament.
Temperament. What else?
I think each child has their own personality as well. Their own character traits. Even though they might come from the same family, they might have different aspirations.
Yes.
One child might, for example, be inclined to academics, while the other might want to do more hands-on things. Not sure what is behind the orientation, but I've seen it happen even in my own family.
Okay. Do you want to share that?
Well, even with my own children.
Yes.
I know two of them like to read a lot, and one of them seems to be more inclined to like business and more hands-on things. So they grew up in the same family.
Yes.
You know, so I'm not very sure what is responsible for the one that likes to do more business and hands-on things, because we encourage all three of them to read a lot. So, but I've seen it happen.
Okay, well, one can offer, and yes, Mr.
I believe it's as was said, it's personality, because I'm a twin and my twin brother, even though we both like some things, we differ on other things. So we both play basketball, we both like to listen to a certain or particular genre of music. But when it comes to making certain life decisions, we differ. So I really believe it's based on the personality as well as that inner aspect of who you are, and it may differ because I may like something different in terms of occupation, and I want to become this person. So I believe it's personality, and I really believe that it has to do with the inward aspect of our being.
Okay. Yes. So basically, then that I don't want to go too much into developmental psychology, but the matter of the psychopathology does seem to suggest that there are certain critical ingredients that can either predispose. So they talk about Rutter talk about 8 risk factors in childhood. Rutter, 8 risk factors in childhood. I believe I may have sent that to you online. I think I may have sent you that handout. I can't. It may have been in week 2's handout, but I do recall sending it to you. You may want to.
Who is the author? Did you say Rutter?
Rutter talks about the risk indicators.
Okay.
But there is a handout that I sent you online, which is in the readings, and I don't have time to go through them tonight. I'll try to go through them on Saturday. But these indicators suggest the resilience versus the vulnerability of children and adults that are prone to psychopathology. So Rutter's very important. Rutter's indicators. And just let me find it here. Just give me a moment. I'll go to my notes. Just give me a moment here. Let me give it exactly what it is. Okay, so I think Rutter is in 1985. That's the year. In other words, what these indicators are, the greater amount of risk a child is exposed to. The greater amount of risk, the greater the propensity for psychopathology to develop. The greater amount of risk, the greater the propensity for psychopathology to develop. Here are some of the indicators I want to give you, so you can write them down. These are, yes? Oh, 1, severe marital discord. Severe marital discord. 2, low economic status. I see someone making a comment. Is it Victor? Each child have different makeup, although they come from the same family. Mr. Nyami, could you have him elaborate, please, on what he means?
He's hearing you, so he may type.
Let him type it, please. Let him type it.
Okay.
The third is overcrowding or large family size. Overcrowding or large family size. The fourth, parental criminality. Parental criminality. The fifth, maternal psychopathology. The sixth, placement of a child outside of the home. Those are Rotter's indicators.
Dr. Mark, I didn't get the last one. I'm getting some feedback.
Are your mics muted, please? Please mute your mics, please. Mute your mics. Okay, the sixth is placement of a child outside of the home.
Dr. Mark?
Yes.
In looking at these, unfortunately, most of our children here in Jamaica are at risk.
I know, Miss Lataya, Miss Dennis, yes.
Whoa.
And why, and how so? Tell us how so.
Boy, I can even imagine right now some children who are, or 6 of these are evident in their lives, especially as a teacher. I have children dealing with probably all 6 of these that are, you know, some of them are displaced in terms of living with some other family member, the parents' criminality in terms of some criminal activities involved in terms of their mother or father, you know, overcrowding. They are from large families, extended families, definitely economical challenges, and marital discord is as if there is not even any evidence of that at all in their families, meaning that mother and father separate and it's the come and go lifestyle relationship that they have to deal with.
Yes.
It's very unfortunate.
Yes, I agree. Anybody else want to respond to what she said a while ago? Her comment? Lataya's comment? Anybody?
I believe it's a part of our lived reality, especially in a Jamaican context. And I think partly it's because of socialization, especially for
Socialization.
right for parents,
Yes.
because especially for males,
Yes.
males tend to deal with issues differently, and sometimes they choose not to deal with issues at all. And I
Mm-hmm.
think that may add to the negative effect that it may have on the relationship. And as a result, the child gets trapped in the middle of all of this. And so it may
Yes.
affect the child in that negative sense.
Mm-hmm.
But
Anybody else? Yes.
Yes, I would want to add by saying that some children will use their circumstances as stepping stone, and they will develop resilience in
Mm-hmm.
having a strong determination that they have to make it in life. So regardless of all the negatives around them, they will strive. While others
Okay.
really won't cannot function in this kind of environment.
I think Mr. Barr, there are two comments. One is from Mr. Barr and Victor Chiana that says, I'm in agreement. What can we do to help change this? Victor says different traits, personality, temperament, and also environmental factors. In the light of these factors, each child from the same family will behave differently. Do you agree with them?
Yes, Dr. Mark, especially with what you just said that Victor said coming off of also Eileen. Because yes, you can have children in the same family that are exhibiting all of these six. But as she said, depending on how they want to use it to their, for want of a better word, advantage. So they
Yes.
might decide that they don't want to stay in that squalor. They don't want to live in this kind of overcrowding situation. They want to have a house on the hill. And so therefore the person who they are seeing as their mentor at this time with the house on the hill is somebody that went to school, worked
Yes.
hard, studied hard, and so forth and so on. The other person might also want to live on the hill, but he
Mm-hmm.
don't have no time for no book. So he decided he going to follow the other mentor now, which is to pick up the gun.
Yes.
Because the money
Yes.
come quick, cause you fool, you have to go school and all of them kind of things.
Mm-hmm.
Right now, I can take the gun, sell two drugs, and I get the money a little quicker. So it just depends on their mindset and how they even want to achieve the same goal and the path that they would want to take to achieve that goal.
But
So Victor, yes, go ahead.
I would just want to say that it's not an easy decision to make,
yes.
because sometimes, especially given the fact that one thing tends to happen after another, and it's like
Yes.
a domino effect. So it's not so easy for a child to say, you know what, I'm going to come out of this because I'm going to look at this person. But I
Yes.
think sometimes it's when there you have intervention, and sometimes it's when person may help to provide a better way, because when they're in the situation, sometimes they're not looking at the way that is provided. Sometimes they're looking at a way to deal with their issue, and
Mm-hmm.
so they may not readily accept what is there or accept a better way, so to speak. And I think sometimes that's when persons may help them and to understand their current situation and show them that they can make a difference. But it's not always easy for them to make that change or to accept that change.
And I
Mm-hmm.
agree with you, but you will admit that there are some children that can because I like to
I
watch
know,
Profile. I
I
like to
know.
watch Profile, and Profile always have these persons who have overcome all kind of odds. And you'll hear from time to time that they will say, from they were small, recognize the situation that they were in, and you have children who
I
um
know.
have that kind of thinking, and some others don't. So it
Well,
just
oh, sorry, Michelle.
so it just depends on the child, the
Yes.
disposition of the child.
But Michelle, in hearing both of you discuss this, a lot of the attention is on the child who is
Mhm.
developing and their mindset.
Mhm.
No, I've always believed that we as a society do not value the family as an institution and
Mhm.
place any emphasis there in development.
Mhm.
We are hoping that the child, despite all these very negative circumstances, will emerge and do well. What do we put in place as a society to help these children? And I get very agitated when we are going to just allow our children in these particular situations with the hope of them emerging because of their mindset. It comes right back to some of these factors. If we look at them, all 6 of them, many of them has nothing to do with the poor child, but the decisions that were made by the adults. And we fail to see too that it's the economical situation of our society that has caused some of these factors to be even at play. So I don't know. Yes, I do celebrate those children who come out, but we need to try push. And I'm not saying we're not doing that or thinking like that, but as a society, we need to place more emphasis there, where it's an institution, a family is an institution that we need to put more into than hoping that individual will just emerge otherwise.
Very good point.
And I agree with you on that point, and it is actually a very good point. But also, too, you can add to that because I mean, we could talk about this forever and ever and ever. And also to add to that, that while it is that we're looking at the child, and while it is that we should look at the adult, the parent, sometimes the children end up having to parent the parent. And we know that that is true. So there are different pieces of the puzzle as we go along. You have some who don't need that kind of an intervention. You have some who need it. So it just depends on, you know, what we find ourselves with at the time. And I understand too, and I agree that we need to put more emphasis on the family. And yes, persons really do try to educate them on not having 7 children with 7 different men, and all of them being boys and have nobody to parent them, and the subsequent behaviors that would ensue. So I guess it's just an ongoing thing that we have to try and combat. So that's a good point.
I see Mr. Barr is making reference to the persons on profile are normally the exception to rule, and for most part got help outside of those communities.
And that is also correct. And again, it just depends on the different personalities and the different persons.
Vanessa, so I'm sorry, go ahead.
I'm saying, and that might be, and that is so. So you have a set who get help, you have a set who are exception, you have a set who have parents who can help them, but you have a set who don't have parents. So you have a whole spectrum of situations going on. And it just depends on which one we want to look at this point in time.
Let's hear from Vanilla from Guyana, from her about Guyana, what about the relating what we talked about in matter of the developmental pathways of equifinality and Rotter's indicators. What do you Guyana's
context? Based on the Rotter's indicators, the first and the last point. In terms of severe marital discord, most children who find themselves in this situation, their parents are not married. In most instances, they're from a single parent or an extended family household where they're often... There's a growing concern in Guyana, for example, where we have lots of women who are security guards now and who leave their children at nights to go and work so that they can provide for their economic needs. And these children are left unattended. You know, some get involved in prostitution, teenage pregnancy, drugs, different things. So the parents are not married. Most times the father is not around. And the last point, children are not generally placed outside of the home. Most times what happens is that they're brought up in an extended family household. So you'd have a mother and her sisters and their children, possibly with a grandmother living in one household.
Okay. I think Mr. Barr made a comment again. I know he mentioned the first half, but I'll read the second half. There has to be a general approach in relation to how we are going to help these parents and by extension their children. So I believe people are saying, with Mrs. Dennis Hall's comments as a teacher, that we are launching into a state of, with the DSM, about disorders of childhood and adulthood. And I want to just make the statement that childhood disorders there is a continuity of childhood psychopathology into adult. There is no distinction. It's a continuous process. So so just want to get into that in terms of the heading, continuity of disturbance, that psychopathology is gradual over time. It's part of the continuum, and it's gradually over time. There is an evolution from the indicators. Rotter's indicator that has mushroomed into full-blown disorders, and these disorders are range from a number of categories, as in the DSM. So the earlier you intervene with a child, the more likelihood of the matter of developmental adaptation, of predictability, stableness, and continuity. The more you're able to intervene. Yes? Is someone making a comment? Hello?
Hello.
Hello, Jean, are you making a comment?
Can you hear me?
I can.
Oh. No comment, thanks.
He's saying, well, let me continue, and I'll comment on Mr. Barr's comment. But so we look at psychopathology as a continuity into disturbance, moving from childhood into adulthood. So the childhood is the precursor for severity in adulthood. So childhood disorders are more mild, and then so the more you intervene at the childhood state, the more likely you are for better prognosis in the future. So you have to intervene in terms of the disorders at the child level. So so the question to ask is, does a disorder is carried over in later life? I say yes. So there are two types of this continuity of disturbances that I want you to be aware of. Two types. One is called the heterotypic continuity. Heterotypic, Hetero, typic continuity. Heterotypic continuity, and this is that some disorders may change with maturation. Some disorders may change with maturation and develop over time into stable symptoms. Let me repeat. I said some, not all, some disorders may change with maturation and develop over time and through stable symptoms. Now let's stop there for a moment. Think about it. Which disorders, if you're in your experience, will change? Do adults have temper tantrums? Do adults have oppositional defiant disorder? Unmute your mics. So the matter of oppositional defiant disorder, which is part of the disruptive disorders of the DSM. Do we find adults having temper tantrums? Hello?
I don't think so, but for the conduct disorder, doesn't it go over into antisocial personality disorder?
That is true. Yes.
I wouldn't say it's temper tantrums, but you may find in adults where their response to certain social situations is unfavorable.
Yes.
For example, where they respond in outbursts of anger or, inappropriately, it's more associated with childlike behavior, not adult behavior.
Explain.
Put it that way. Well, for example, if in a work environment a constructive criticism is offered and that person gets very upset with the colleague because they feel that they shouldn't criticize them. So for me, that's like and they respond angrily to the colleague. So it's not a temper tantrum, but at the same time, it's sort of like a childlike behavior. But I think although they might respond in a childlike manner, we don't classify it that way because they're an adult.
Any comments on what she just said?
No.
Okay. Go ahead. Tell us why. Give us the evidence.
No, well, like you said, you know, they may get upset and, you know, carry on, and you consider it as anger. So situations like those, you wouldn't call it, may seem childlike, but you pretty much not going to call it temper tantrum because they're adults, and temper tantrum, that's basically used with children. So maybe what you would say is, oh, that individual needs anger management, you know what I mean? But not to classify it as temper tantrum, really.
But let me give you another scenario. Would you say that, well, some people do borderline, but I'm jumping the gun. Wouldn't a borderline personality disorder behave in terms of their temperament, they behave through a fit when they have issues? Would you not say that? Would that become temper tantrums?
Yes, that's a characteristic of this.
Yes.
Of borderline. But I don't know. But I guess it could be classified as temper tantrum, as I said before. But I just never heard anyone call it temper tantrum when they're referring to adults.
Okay. Well, in continuing with the heterotypic behaviors, that true, I agree. You wouldn't find maturity comes into play, but the same symptoms of childhood will probably manifest itself different in an adult. So whereas you find a child showing oppositional behavior, in an adult you'll find more passive aggressive behavior in different ways. You see that. Do you see the difference?
Let's talk about that.
All right. The second thing I want to mention is called homotypic continuity. Homotypic continuity. These are varying degrees. Are you hearing me?
Yes.
Could you just
Yes, Dr. Ma.
Yes, Dr. Ma.
These are very, I'm trying to get my thoughts together. There's a lot of static I hear. I'm hearing static. Thank you. I'm saying that these are varying degrees. Good. These are These are varying degrees of behaviors that are based upon duration. Duration of symptoms. Varying degrees. So whereas it may not necessarily be due to the maturing of the individual, it's more due to symptoms. How long it is, how severe the symptoms are. So homotypic continuity is dealing with the duration of symptoms. Heterotypic deals with changes in the individual maturation of the person, and the person becomes stable over time. So what it's suggesting then is that in a heterogenic continuity, in continuing, that the more variation that the person has in being able to navigate between adaptation and psychopathology. If maturation is to the point where the person is maturing enough, the symptoms are likely to stable. However, without that buffer of maturation in the homotypic continuity, it's more related to severity of symptoms because there's no buffer. And so the person may progress from a point of mild to severe symptoms. And this is where you have, again, you have the disruptive disorders as a category in children. It can also lead to personality disorders, antisocial, somebody said it. Or you can have in children, you can have depressive disorder, but you can have a major disorder recurrent in an adult, because each disorder has they continue. If the issues are not resolved, they can continue. Unmute your mics. Any questions?
None from me, Dr. Ma.
I'm hearing from Marshall. The term temper tantrums are usually used when referring to children. Adults do, however, mimic that behavior where they display consistent anger, anxiety. Do you agree with her? Do you agree with her?
Not sure.
Yes, Miss Hall, go ahead.
No, I was just mumbling that I'm not sure.
Miss Hall, go ahead.
No, Dr. Mack, I was just mumbling that I'm not sure.
Okay.
Dr. Mack, can you read it again for me, please?
The term temper tantrums are usually used when referring to children. Adults who, however, mimic that behavior where they display consistent anger, anxiety. Does she have a point?
She has a point, but borderline. She has a point, but borderline persons, one of their criteria is that they throw temper tantrums. So if that is a criteria, then it means that in adults, from time to time, they probably would have that happening. But she does have a point that the generally when we hear temper tantrums, our minds immediately go to children.
That's correct.
But we also find it as a criteria on some of the personality disorders, at least one. So she has a point.
Anybody else?
As it relates to an adult manipulating situations, can that be consistent with throwing a temper tantrum? Like they must have their way, and if they don't get their way, then they're gonna be acting out as adults. So wouldn't that be equated? Couldn't that be equated with throwing a temper tantrum?
Could that be what?
Challenge.
Equated, with throwing a temper tantrum.
I'm trying to understand what. Come again. Explain again.
Okay. For example, I don't know if the narcissist person who would want to always be a person who is manipulative, an adult who is manipulative.
Yes.
And if he wants to have his way and he's not getting his way, then he will act in a particular manner. We could equate that to a child not wanting to watch television as long as he wants to.
Okay. All right. Be careful, because there's a difference between a narcissist and a child who is egocentric. Totally different. Why is there a difference? In a narcissistic personality disorder, we're jumping the gun here, but in a narcissistic personality disorder, the aim is that there is a matter of power, and there is a strong need to dominate and be superior. In an egocentric child, pre-operational child, the child the child cannot, in terms of the concrete operations, the child a child who is egocentric, that's the focus of their need because they want their needs instantly gratified. But it doesn't necessarily mean that they're going to be narcissists for the future. Do you understand that? Okay. It's a normal developmental trait in children, in Piaget's cognitive development. That's normal. But a narcissist, it's a distortion or a fixation on the person's relationship, and so it's almost like narcissism is a defense where the person it's almost like a reaction from it because the person really there's an underlying need for inferiority and insecurity, but they use the domination and superiority to cover or to compensate for the deficiencies. Do you understand? Is it clear, Miss Osborne?
Dr.
All right. I think any other question before we continue and wrapping up? Any other questions?
None from me, Dr. Mac.
Dr. Mac, in terms of the temper tantrum, in my head, I'm just picturing a child in the moment acting out through whatever means, in the moment of not getting what they want.
Yes.
Acting out in some very immature way, but would be suitable since they're a child. That's why I said I have a challenge seeing an adult throwing a temper tantrum, maybe because of my understanding of what it is. But I can agree with the persons who have discussed ahead of me that it will manifest itself in different ways in adulthood.
Well, okay. Let me see if I can put a enlightened spin on the discussion.
Yes, sir.
A temper tantrum in a child is based upon it's really found in pre-sensory children who first of all they look at object permanence is one where that objects that are in focus tend to remain. So a child is in an egocentric stage tends to throw tantrums because they feel that it's a learned behavior. So they feel that if I behave in a way that I cannot regulate my needs or my gratification or the suspend gratification, I need it now. And so children throw tempers for a lot of reasons. So a child who in a normal developmental stage will do that, but there are ways to control tempers that they have to learn to suspend gratification. However, there is also a difference with a child who has had an attachment issue or attachment difficulties and can throw the same temper tantrum. That's pathology. So you look at temper tantrums in terms of normal development and temper temper tantrums in terms of abnormal development, where children get into very, very difficult emotional dysregulation because the nature of the environmental stability, or there's a lack of consistency and predictability has been there is a sort of a disruption, and so the child is responding. So you find children who are having some very disorganized attachment, we haven't talked about that yet, will display that kind of behavior, normal from the other child, because a child who, based upon structure, will be able to suspend gratification. But a child who is in an adaptive state in terms of the developmental pathway will tend to display that kind of abnormal behavior. So they may in terms of the temper, they may break things, they may destroy property, they may hurt animals. That is a serious. That's a development of a conduct problem. Is it clear?
Yes, Dr.
Hello?
Yes, Dr.
Yes, Dr. Mac. Yes, Dr. Mac.
All right, let's look at this, and then we want to wrap up shortly. I want to talk about, before I forget, Braun. I talked about it before. Let me give you some information about Braun-Fenn-Brenner's ecological model. It's very important. Bronfenbrenner's ecological model. It's not in your notes, you need to take some notes, please. So,
can you spell that for me, please, Dr. Mark?
I will. B-R-O-N-F-E-N, Bronfenbrenner. B-R-E-N-N-E-R, in bracket 2004. That's when he did the research.
Okay.
So it's not that old. It's pretty recent.
Yes, Dr. Mark. Right.
Ecological model. Remember we talked about the pathways, the different sub models of. Okay, let's look at this. Very important. For him, it's the interactions between the individual or his or her context. Remember I talked about that, the importance of context in culture. Remember I talked about that?
Interaction, yes, Doctor.
Between the individual and his or her context or environment. And it is in terms of 5 developmental systems. 5 developmental, or add to it environmental systems. 5 developmental or environmental systems. 1. The first is the microsystem. And when we talk about this, I want you to be able to relate that to the DSM when we get to it. 1, especially in children. 1. The microsystem is the child's immediate environment. The child's immediate environment. And these are relationships involving the home, school, the child's immediate environment, such as the home, school, and neighborhood. Home, school, neighborhood. Also involves the child's relationship with parents, teachers, and peers. The relationship between the parents, teachers, and peers. Put in bracket the most important. Put in bracket the most linked to child psychopathology. A disturbance of continuity is linked to this microsystem. And 2, the mesosystem. M-E-S-O system. Mesosystem. So this is then, it is based upon an interaction between the microsystem. It is based upon an interaction between the microsystem and, excuse me, the influence of family factors on the child's behavior at school. The influence of family factors on the child's behavior at school. Remember I talked about externalizing versus internalizing behavior earlier in the course? Do you remember that? Do you remember that? Externalizing versus internalizing behaviors, where I said that a child tends to, when a child internalizes behaviors, it's due to intrapsychic conflict.
Yes, Dr. Mark.
Externalizing is when the child takes the conflict outside of him into the school or outside of the home. Is that clear?
Yes, Dr. Mark.
So that is the mesosystem. So let's let's take an example of a developmental disorder which we'll be studying. So when if the behavior in a child, for example, is more prominent in the home, it is more linked to it's more microsystem driven. If the behavior goes into the schools, then it's mesosystem driven. So, for example, a child who is displaying behaviors at school, but when the parents are called into the school and it says, but he's not behaving that way at home, what is that saying? What is that saying? That the child is what? The child is what? Externalizing behaviors outside of the microsystem, correct? Hello? Hello?
Dr. Mark.
Yes,
Not
Dr.
yet. Okay.
Yes, Dr. Mark.
So be careful. So you need to ask parents and note: is the behavior heterotypic? Is it consistent over across all factors, or is it just only if it's only in a home, then it's based upon what's happening in the home? The third I want to talk about is called the exosystem, EXO system. Miss Hill, do you have a question? Hello? Nataya, do you have a question? Do you have a question? This is, excuse me, the ecosystem refers to the broader environment. Refers to the broader environment that affects the child's immediate environment. For example, these are the parents' workplace, mass media, school board, community agencies. That's called the ecosystem. Is it clear? Any questions? Unmute your mics. Any questions?
None from me,
No,
Dr.
Dr. Mark.
Okay, very clear. Good. Sorry?
I said I'm still trying to put everything together.
Okay. The macro system is another one of the ecological, the macro, MACRO system. Macro system. This is based upon the environment and culture impacting the child. Economic conditions and the role of society's values on the child. That's the macro system. Macro system. The final is called the chrono system. Chrono system, CHRONO system. These are basically environmental events that impact the child over time. Environmental events that impact the child over time. it can have long-term or short-term effects on the family dynamics. So this is time-driven, time-oriented, and impacts the family dynamic. That's the Chronos system. Unmute your mics. Any questions?
Questions? On for me, Dr. Mac.
Is it clear, everybody?
Clear enough, Dr. Mac.
All right. I think we're going to wrap up now. I will be continuing wrapping up with the attachment theory on Saturday, and I'm going to be looking at the DSM, and I'm going to be going through diagnosis and the DSM in total on Saturday. So
okay,
please, have you looked at the clips on DSM-5?
Yes, Dr. Mac.
Dr. Mac, in preparation for the post. Okay.
Yes. Did you also look at looking at abnormal behaviors?
Briefly, because it was difficult to navigate to find the clip, but Mr. Naomi was able to send the clip to us.
Okay.
I've been able to see it in its there.
Okay. Try to go individually because of the licensure issues we have problems. So watch looking at abnormal behavior, looking at the DSM-5, and we're going to be talking specifically about the DSM-5 on Saturday. I'll spend more time on that, and I'm going to tie in the attachment theory and try and tie in object relations as to why we need to know about object relations and attachment. All right?
Yes, Dr. Mac, and the other thing, I don't know if everybody saw your email today as it related to the postings, the fact that you want us to react to the videos. And so the postings should really surround the videos and then whatever other supporting we can find.
People were reading, not mentioning the main reading and using other articles as support. It's really true that you're supposed to focus on the article that was given as a reaction, and you can use other supplemental, but the article and the videos must be incorporated.
So in a sense, you want us to watch the videos, and whether we agree, disagree, or have some kind of a thought on it. Then
no. Yeah, there are two types of videos I gave you. One was the videos for the class, but I gave you several videos to.
No. I'm talking about the ones for the class, Dr. Mac. The one with I'm talking about the ones for the class. The three for the class. Mental illness and the 2 DSM people.
That has nothing to do with the post, though. That has to do with our class.
Yeah?
No, Dr. Ma. There were 3 videos that were labeled for the discussion forum.
Yes, that's what I wanted you to watch. There were 2 sets of videos. One was for the class.
Yeah.
And the other set of videos was for the discussion forum. You have to watch it. Yes.
It's a discussion forum that I'm talking about, Dr. Ma.
Yes, those are
2 of the videos for the discussion forum are on the DSM.
Yes.
And one is on abnormal behavior.
Yes.
Mental illness, sorry.
Mental illness. So I'm saying, so in watching those 3 videos, 1 on mental illness and 2 on the DSM, then based on what we are hearing in those videos, the comments as it relates to whether or not it makes sense or to have done that, we react to that.
Yes, whether or not you disagree or not, you don't have to, there's no right or wrong, whether or not you disagree with the article and why.
Dr. Mac, seeing that we really haven't gone through the DSM yet to really understand fully exactly, especially what Colin Ross was speaking about, because he kind of went very fast and was talking about the different variations of delusions and schizo and where's what and what is what. It was a little bit difficult to try and piece it together to even have a thought. So I'm wondering.
Do your best with it, Ken. I'm not expecting you to. I mean, you have not done the DSM yet. I agree, but I want you to primarily react to the article on the DSM that I gave you.
All right, then, Dr. Man.
And do the best you can with the videos as you understand it.
All right, Dr. Mac. Thank you so much.
And that's due tonight, Dr. Mac?
tomorrow night.
Tomorrow night.
Oh, thank you.
You alone will be doing that one tonight, Latia.
Yeah. Okay.
Okay, ladies, and it's getting a little late. Are there any other questions?
Not at this time, Doctor.
All right. Well,
Not from me now,
For the group presentation, would you consider, Dr. Matt, risky if a group decides to do their presentation in the form of a case study?
of what?
Case study.
No, of course not. You can do whatever you want. If you want to do a case study, great. We're having static. We're having some static. Hello? Hello?
Hello?
We're having static. I'm saying to Miss Osborne, yes, you can. You feel free to do a case if you can, and that's due on the 8th of December. That's next week, Monday, correct? Yes. Okay. All right, ladies and gentlemen, I think we need to conclude tonight's lecture. And thank you for coming. Thank Mr. Nami again for his faithfulness and helping us with the technology. At this time, Ms. Husband, could you close in prayer for us, please?
Father, we just want to thank you for your kindness to us. We thank you that you have allowed us to have this discussion tonight. We have the Holy Ghost that you heal in a way that we be able to make communication or whatever it is. Lord, you lead us and guide us to this time.
Amen.
Amen. Amen. Thank you. Thanks, Dr. Mac. Bye, guys.
Thank you,
Thanks for the
Doctor.
exposure.
Have a good night, everybody.
And the same
Bye.
to Dr. Mac. Okay,
Okay.
bye. Bye.
Bye-bye.
Bye.
Bye, Vanessa. Good to see you.
Bye, Bishop.
Bye.
Good to see you too,
Bye.
Michelle.
Bye, Eileen. Bye, Latia.
Bye-bye.
If I can't see you.
All right.
Good night, everybody.
Bye.
Night.
Bye, Dr. Mac.
Bye-bye. Mr. Nami? Mr. Nami?